Guys, I'll be talking about osteosarcoma. It is also called osteogenic sarcoma as it is the malignant tumor of mesenchymal cells with formation of osteoid or bone by the tumor cells. Talking about classification, on the basis of clinical setting, it can be divided into primary osteosarcoma and secondary osteosarcoma. Primary osteosarcoma is common. It occurs at the age group of 15 to 25 years and there is no pre-malignant conditions and it is more malignant. Secondary osteosarcoma occurs after the 45 years of age and it is associated with pre-malignant conditions like Paget's disease, fibrous dysplasia, irradiation to bone, multiple osteochondroma, multiple enchondromatosis, and it is less malignant. On the basis of dominant histomorphology, it can be osteoblastic with lot of new bone formation, chondroid, basic cell being cartilage cell, fibroblastic, basic cell being fibroblast, and telangiectatic, osteolytic, predominantly lytic tumor. Talking about spread of osteosarcoma, on local spread, it locally spreads to the cortex and soft tissue, giving rise to radiological findings like Codman strangle and sunburst appearance. Locally spreading to the medullary canal, it replaces the marrow, and despite of its aggressive nature, it rarely invades the epiphysis. On hematological spread, hematologically it spreads to the lungs, brain, and to the other bones. Lymph node involvement is unusual. On primary osteosarcoma, it occurs at the age of 15 to 25 years and the commonest sites of origin are the distal femur, proximal tibia, and proximal humerus. It most commonly occurs in the metaphysis of these bones. Gross appearance, which depends upon the histomorphological types. In osteoblastic type, it looks like greyish white, hard on touch, and gritty feeling on the cut. On chondroid type, it is opalescent and bluish grey is seen. On fibroblastic type, fish flesh sarcomatous appearance is observed. In telangiectatic type, there is large area of tumor necrosis and blood-filled spaces within the tumor masses. On seeing microscopically, anaplastic mesenchymal parenchyma with tumor cells surrounded by osteoid is seen. Talking about symptoms, the patient presents with pain, swelling, and the pain is constant, boarding type, which worsens as the swelling size increases. History of trauma is common, which draws the attention of the patient. Sometimes pathological fracture may be the presenting complaints. Talking about signs, there is swelling in the region of metaphysis of the affected bone, and on examining the swelling is warm, tender, and the margin of the swelling is not well defined, suggestive of malignancy. And skin over the swelling is shiny with prominent veins. Due to swelling, movement of adjacent joint is limited, and swelling may compress neurovascular structure of the limb, producing symptoms due to the compression. There may be enlarged lymph node, which is usually reactive, and there may be pulsation in the tumor due to high vascularity. Talking about investigation, we perform the X-ray. In X-ray, we see the area of irregular destruction in the metaphysis of the affected bone, and sometimes this is overshadowed by the new bone formation, and the overlying cortex is also eroded. We see the periosteal reaction. When tumor lifts off the periosteum, it elicits periosteal reaction, which is irregular. But in osteomyelitis, this periosteal reaction is smooth. Codman's triangle is seen. This is a triangular area of subperiosteal new bone formation. Sun ray appearance is seen. When tumor reaches the soft tissue, the new bone formation occurs, which gives the sun ray appearance. Serum alkaline phosphatase is also increased, but this is not diagnostic. Biopsy is done, and open biopsy is the confirmation of the diagnosis. Now talking about the treatment of the osteosarcoma, our aim of the treatment is to confirm the diagnosis, then investigate the extent of the tumor, and then execute the adequate treatment. On confirming the diagnosis, on biopsy we see the new bone formation, which is pathognomic for the osteosarcoma. If on biopsy it is not seen, that new bone formation is not seen, then clinical and radiological picture can be taken into consideration. And for the evaluation of the spread of the tumor, chest X-ray is performed where long metastasis is observed, and for the soft tissue involvement, we perform the CT and MRI, and we perform bone scan to find the intramedullary spread. and for the treatment of the tumor, which consists of local control and control of the metastasis to the distant site. As osteosarcoma is highly radioresistant, radiotherapy is not performed, but for the surgically inaccessible sites, we can perform the radiotherapy. So it is treated by chemotherapy, followed by limb salvage or amputation surgery, and again followed by chemotherapy. On performing chest X-ray, when chest X-ray is normal, we do the local control of the tumor. For that, we perform the limb ablation surgery or limb saving surgery. And for the limb ablation surgery, we do the amputation of the affected limb and disarticulation of the proximal limb. It has good prognosis. Since the limb is ablated, patient uses artificial limb. And in limb saving surgery, we do the radical resection with reconstruction, arthrodesis is done, and joint replacement is performed. It has good prognosis. And for the prophylactic control of metastasis, neoadjuvant chemotherapy is used before local control and adjuvant chemotherapy is used after local control. And for the chemotherapy, we use high-dose methotrexate, citroboron factor, indoxan, and cisplatin. If chest X-ray show metastasis, then CT scan is done, and in CT scan, if there is single metastasis, then we do resection of the metastasis and local control of the tumor by limb ablation surgery or limb saving surgery. And if on CT scan there is multiple metastasis, then we do palliative ablation and chemotherapy, which has poor prognosis. In new concept, there is immunotherapy. In immunotherapy, tumor from the patient is implanted into the sarcoma survivor, and sensitized lymphocytes is obtained from the survivor, and this sensitized lymphocytes is infused into the patient, which kills the tumor cells in the patient. The patient should follow up every 6 to 8 weeks for recurrence or secondaries, which is usually in the chest. And if the recurrences and secondary are noticed, then early diagnosis and treatment can be done. And for the prognosis, if the osteosarcoma is not treated, then death occurs within 2 years. And if there is detection of metastasis, then death occurs within 6 months. And if the osteosarcoma is treated with surgery alone, then 5-year survival is up to 20%. And if it is treated with surgery and adjuvant chemotherapy, then 5-year survival can be up to 70%. This is all about osteosarcoma. Thank you.